That being said, our next speaker is a brilliant oncologist. I hope I'm not setting the bar too high for you, but this is what is being told about you. You lead, amongst others, the presidential campaign for oncology in Egypt. And for those who don't realize, but Egypt is a huge country with 110 million people, and they have a pretty high standard of care and science. What makes you even more remarkable that even though you circle in the highest set of people, you still stand next to your patient, and through your work, you help them overcome silent despair. So please give an applause for Ahmed Hassan Abdelaziz. I hope this one works. Yeah.
Thank you very much. Very impressive. I'm flattered. Right. So, first of all, I'd like to thank Peter and Ilona for inviting me here today. It's very interesting. I have never attended a meeting like this before, so it's quite a rich experience. And they asked me to give a talk about my work in Egypt, but actually it's not my work. It's our story. It's a story of me, the team, and the patients as well. But before I do that, I hope I knew that dancing was allowed in the meeting. I would have prepared some Egyptian or belly dancing moves because I'm a terrible dancer. I might be an okay oncologist or a good oncologist, as some say, but I'm a terrible oncologist as a terrible dancer, as mentioned by many, especially my kids. So I will stick to the classic way. So my topic today will cover two main things. First of all is our experience in the National Breast Cancer Campaign, messages that we've learned, the barrier and gains. The second part is challenges to conducting research in the developing countries, particularly in our example in Egypt. Why breast cancer in particular? We all know that breast cancer is the most common cancer globally amongst women. It's a large burden. It's an onus on any kind of a society. It is the most common cancer in Egypt and in other parts of the world. As you can see, the countries in dark blue have the highest incidence of breast cancer, and Egypt is not an exception. And despite actually the oldest evidence about breast cancer is Egyptian, this is the famous Edwin Smith papyrus, which is more than 5,000 years old, and it talks about 8 cases of cancers that the ancient Egyptians treated by cutting them out. And they describe this as, if left untreated, it is a lethal disease. It's a lethal bulging of the breast, and it is lethal. This was written by Imhotep, who was actually a famous religious scholar, a philosopher, a physician, and a politic as well. And despite that we recognized breast cancer very long time ago, nevertheless, we're not very clever in treating cancer. And this is the GloboCan map of how well we're treating cancer according to the 5 years and 10 years overall survival. The darker the red color is, the worse the outcomes are, and unfortunately Egypt is sitting on the top right part of Africa, and it is a crimson color rather than red, so our mortality rates are quite high. I was practicing in the UK for a long time, and then in 2015 a charity group called me and they said, we are gathering and we are collecting donations to construct a big breast cancer institute, and it's a charity hospital for free for everyone, and we would like you to come and lead this project. So I went back, I repatriated in 2015 because number one, breast cancer is a big job in my country. Secondly, because it has been a matter of my master degree and my PhD in the United Kingdom. And the third reason, which is actually more important than those, is that my wife wanted to go back to Egypt. So I went back to Egypt. I led this project. This was a donation from an aristocratic lady who passed away with cancer, and she donated the land plot where she lived. She lived in a mansion, and she donated the land for the breast cancer project. And then this charity group asked me to form a team. We hired the personnel, nurses, physicians, radiographers, admin, put guidelines. We devised local guidelines to suit the Egyptian population. And we ran awareness sessions in many areas of Egypt, going to remote areas. We ran marathons. We cycled different parts of Cairo. We even organized some musical concerts and some dancing concerts in order to spread the word for breast cancer awareness. However, this was not enough. This was just organizational or institutional work. So it's not enough to cover a country of 110 million population and 1 million square kilometers. So we needed to take this to the national level. And in 2019, we had a call from the presidential office that they are getting many kind of official reports describing delays in surgeries and delays in starting treatment for breast cancer patients and in cancer patients in general. And there is a need to organize a national project to address this issue and to eliminate the waiting list. That's number one. And number two is to improve the awareness and improve the outlook of cancer management in Egypt. And breast cancer was chosen as the top priority. It is the case actually globally, because it is a cancer that if you spend good money on and if you follow good medicine, then you can see quick and rapid outcomes and improvement in cure rates and survival rates. The first thing that we worked on is that we do not have, like in many developing countries, we do not have good registry. We do not have good data. We've heard this morning lots of talks about how sharing the knowledge and sharing the information is a challenge, and we have a lack of knowledge about the actual figures in many developing countries in Africa and in different parts in Asia about how we're doing, how well we're treating cancers. Cancer registers are quite defective. So a good starting point was to get a benchmark, get baseline where we stand at the moment. So we looked at all the Egyptian literature, and what we saw was striking, but this is not very different from other parts of Africa. We noticed that actually more than 50% of breast cancer patients are diagnosed at stage 3 and 4. So this is the main reason why we're seeing, of course there are many other reasons, but this is the main reason why our survival figures are failing, because more than 50% of our patients are being diagnosed in stage 3 and 4, and most of these patients will eventually, unfortunately, die of their cancer. We published this in the GCO, and we used it as a benchmark. Then we, as the executive board for the National Breast Cancer Program, we devised the 8 pillars of the National Breast Cancer Initiative, and these are the awareness, because we need to work on the awareness of the Egyptian population to prompt them to go for screening, to seek attention, to achieve early detection, which is the second pillar. The third thing is to speed up the process for diagnosis, work on patient navigation. Number 4, management and survivorship. Number 5, data management and clinical governance. Number 6 is working on constructing centers of excellence. Number 7, training and capacity building. And finally, but not the least, is research. And we realized that it will not be possible if we stick to the international guidelines. If we say, okay, we will do breast cancer screening like in the US, in Western Europe, it will not work. We don't have the infrastructure for that. We don't have the mammograms. It's not actually the recommendation of the WHO. The WHO says just follow whatever suitable for you. And we found that what is suitable for us is to rely on clinical breast examination. So we devised this pathway, which essentially invites all Egyptian women from age 18 and above to come for a clinical examination. So from age 18 to 35, it will not be clinical examination because it's very unusual to see women with breast cancer at this age group, although we do see, but it's not very common. It is mainly for awareness, education, and they're given a booklet and they're sent home. Ladies from 35 years and older, they get a clinical examination, and if they have any clinical finding or ambiguous finding, then they are referred to the tertiary referral center. And because, again, we are a large population, a large country, we could not rely on the cancer centers or the university hospitals. We had to utilize the primary care units. So we relied on 3,500 primary care centers. We trained, because the catchment population is more than 30 million Egyptian ladies, so we had to rely on these because they are distributed all over the country. We organized training to the GPs and the midwives, who are very credible healthcare professionals in many parts of rural Egypt. We've done trainings in Egypt, in Cairo, and in the villages and in remote areas in Egypt to improve the awareness first of the GPs and of the physicians, and then we can use them to transmit the message to the public. And what are the outcomes? So after 2 years, we were able to detect 10% of the population having abnormal finding. And from these 10%, we diagnosed 5,000 patients, and we compared the patients who were diagnosed through this scheme, through this program, in comparison to our older literature that I showed you earlier. And to summarize, stage 3 or 4 were 29% after 2 years in comparison to 58%. So, and this is below the threshold recommended by the WHO, with a caveat that this is only applicable for patients who came to the screening program, the early detection program. So many of the breast cancer patients were still going through the old channels, and they were getting diagnosed at the stage 3 or stage 4. We presented this at the last ESMO, and that actually after more than 3 years, now it is 20% stage 3 and 4, while 80%, but again, these are the patients and the population who presented to the early detection project. So our main concern now and our main focus now is to get all of the Egyptian population to go through this program, not only those who were catered for during the past 4 years. But other gains from this project actually was that we were able to get a holistic view of the process, the navigation through healthcare system, recognize the areas of deficiency, do training and capacity building. MDT implementation made a big difference. It is now mandatory that we have to diagnose and treat the patients through MDTs. If the patient is not discussed in the MDT, the provider will not get reimbursed for the diagnostics and the treatments. So it is obligatory. And this is very relevant to our practice in the developing countries. There are many data and literature to support that without introduction of any novel techniques, robotic surgeries, immunotherapies, by getting people, different disciplines to sit together and discuss the cases, we can improve survival. Clinical audit was also carried, and we were able to generate a wealth of data which we'll publish very soon. One of the gains was that we managed to improve also the histopathology levels in Egypt, because this was one of the weakest links in Egypt. We have a massive defect in subspecialized pathologists, and we had a CAP accreditation for the first time in a government. This is the whole team. This is the work for the whole team. And we had a recent visit 3 days ago. We were very busy with the WHO and the IARC team, who came and visited for a week to inspect the process, inspect the program, and just bringing you a couple of their feedback on their LinkedIn profiles, just saying how they really enjoyed and how they were impressed with the work done through the national program. Monica is staring at me that I have a limited time, and I'm not afraid. Actually, I'm afraid to miss my flight actually in 3 hours, but I'll just go swiftly through the remaining slides. So challenges to our program where COVID hit. The program was launched in 2019, so it actually delayed the progress of the program for the first 2 years. The financial sustainability was a big issue, but we are lucky is that the call for this project came from the presidential office, and in our part of the world, in the Middle East, and in the rest of the world, by the way, but in the Middle East and developing countries, if you have political support, it makes things much more easier. And we have political support, so and we have to some extent, financial sustainability. Challenges also, we had fragmented systems. We have the private practice not participating. The military hospitals not participating. So we still have some islands which are not getting under the umbrella of the National Breast Cancer Program. We have lack of some expertise. I've already referred to the histopathology, but we also have lack in data analysts, subspecialized radiologists and histopathologists. Lack of clinical governance, although this is improving slightly but steadily. Lack of patient representation. So this is a patient advocacy group. This is something that we're really lacking. For those of you who attended the St. Gallen last year, this is Benjamin Anderson demonstrating how actually the civil society and patient advocate are the third pillar in improving the outlook of cancer, and particularly in breast cancer. So it's the government, the healthcare providers, but also the civil society, including the patient's advocate. And we have a challenge getting the advocates in Egypt, and Peter and Ilona are aware of that. We have lack of support to these groups. We have not enough training for these groups. We have so many work to do in this regard. Just a final word on cancer research issues. By the end of this century, 80% of the population will be coming from either Asia or Africa. And by the end of this decade, actually, there will be an increase by more than 80% of the cases of cancer diagnosed in the lower income countries. Do you know, for 50 years, by how much the number of cancers are going to increase in lower and middle income countries? 100%? Okay. Actually, in lower middle income country, 400% increase. So there is a massive increase ahead of us. And in the middle income countries, it's 168%, but in higher income countries, it's 53%. And the causes are many, but mainly due to the changes in the population pyramid. So if you look at the population pyramid in Egypt and in Africa, you find that it's a pyramid, it's a typical pyramid. In few years, with the improvement in healthcare and the elimination of communicable diseases, you'll find that this population pyramid is changing from a pyramid to the kite kind of shape. And you'll see people living longer with more cancer. Cancer is an age of elderly. You have increasing life expectancy, growing urbanization, and lifestyle changes. So we'll have an exponential rise in cancer cases coming. And despite that, research funds takes around 20% of the global budget for research, which is the second in the league of research funding after software and hardware. And most of this is going to cancer research, by the way. However, little research has been conducted in these countries, in lower and middle income countries. And of all three trials of anti-cancer therapies, only 80% are conducted in lower and middle income countries, which is a shame. I attended a meeting in Nairobi last year, and it was a pharma organized meeting, and they said that they scanned Africa to see which centers have the infrastructures to do research, and they said that it's between 60 to 140 centers across the whole continent are able to conduct research. It depends on the level of research. So phase 2 is different than phase 3, different than phase 1, of course, but maximum is 140 sites. And these are limited to North Africa and few other African countries like Kenya or Uganda, Nigeria and Ghana, but there are less than 10 countries in Africa have the ability to conduct research. In the Arab world, 22 countries constituting 5% of the population, and we're contributing by only 1-point-something% to research. So it's a shame again. There are many challenges. I'll just go quickly. The perception amongst the public, it needs a lot of work. There's still many of our patients, when we talk about research, they say, we are being treated like rats. This is very investigational. So we need to work on awareness to our patients that this actually will benefit all, and including the patients. Provider, there are many challenges: fear of change, lack of leadership, competing priorities, lack of protected research time. We're all running after the money to secure our wages and secure our finance. Lack of formal training in research methods, and ill-equipped to conduct clinical trials. There are many challenges at the level of the system. including data registry issues, as I've referred to, and I was talking to Peter about that. We need to collaborate. Incomplete documentation, fragmented systems, data confidentiality and ownership issues. When it comes to regulatory approvals, it's a nightmare in the developing countries. And sometimes I actually fail to bring clinical trials because the time frames for these clinical trials internationally I was not able to meet. The infrastructure, as I said before and alluded to, that we have very limited number of centers with abilities to conduct clinical trials. And most of the clinical trials are conducted by pharma. And pharma, although they are very good partners sometimes, but they have their agenda. They are business, private business at the end of the day. They have their interests. They give very small shares of the patients in the clinic. I'm conducting PI in 3 international big trials, including more than 6,000 breast cancer patients globally. And in Egypt, the whole of Egypt, we're getting a quota of 30 patients from 6,000 patients, for example, in one clinical trial. In my center, we are the top recruiters. We have 9 patients. So how will this impact the whole population of 110 million if you're having 9 or 30 patients only? Can you tell any kind of information when this trial comes out? No. The only benefit that I see is that my team are getting the experience of working in a clinical trial. That's it at my center. But otherwise, it does not have really a tangible impact on the population. And finally, these are my recommendations. We need to improve data collection and registry. We need to adopt clinical governance and cost effectiveness. We need to prioritize research needs. We need to reduce cancer burden and stage, improve treatment access and affordability, look at cost effectiveness. We need to prioritize investigator-initiated clinical trials rather than industry-initiated studies. We need more room for patients and advocates, definitely. And we need to collaborate, the collaboration of all stakeholders, and particularly the policymakers, the payers, the public support, and the patients in the center of all that. Thank you very much.
Thank you so much. I think I did not exaggerate at all when I announced you. We have time for one remark or question. All the way there. Let me just run. Thinking of you, Lex.
We just go continue. Oh,
all right. Okay. I worry when I see you because I see dancing coming and I'm not natural. I cannot bring any natural dance moves. So sorry.
Thank you so much. Very great to know the whole story of what's going on with the oncology and breast cancer in Egypt. I didn't have much knowledge about it, to be honest. But coming from the side of, I'm from Iran, a Muslim country, and I want everybody to know in a Muslim country, it's 100 times more difficult to raise awareness on a topic like breast cancer. It's not only seen as part of the body, it's seen as the hidden part. You have to hide it as a woman. And that's my question would be like, are there campaigns raising awareness in rural areas? Because I can imagine it's shame to talk about it. It's directly linked everywhere. And here in Western Europe, there are still campaigns of awareness raising to increase sensitivity about, okay, this is just another tumor in another part of body, but it takes away a woman's sexuality. So how is it that rest in Egypt? Is there any, I cannot imagine there would be, I'm familiar with the feminism in Egypt and the social constructs there. So I cannot imagine if the government is supporting it to raise this kind of awareness on this is not taking a woman's sexuality away, or if the public is doing that by themselves. Thank you.
Thank you very much. You're absolutely right. And actually, this is one of the things we took into consideration when we devised the program. It is mainly it focused more on the rural areas. And we relied actually strictly on female doctors at the beginning. And the midwives, they have high credibility in Upper Egypt and in villages. And it was mainly through women to attract other women to come and, avoid any kind of awkwardness being examined by opposite sex. This is one thing. The other thing is that actually, when and this was also mentioned when I attended the last year's meeting in Kenya, that I think it was in Uganda, when they also had some program, and the program was not very successful because many women knew that treating cancer meaning taking their breast away, so they stopped going to the program. So there is a need to work on improving the awareness for ladies that if you come early, you will be diagnosed at an early stage. We will take only the tumor and we'll be able to retain the rest of the breast. This is one thing. The other thing is that we did not have in the national public sector funding for reconstruction of the breast. We introduced that, the immediate reconstruction of the. We did not have fund to incorporate silicone and prosthesis implants, but we had fund to do what we call the autologous, the self implants. So this is now available for the past 4 years, and we've mentioned this several occasions in the social media, in the campaign, in the public campaign and awareness campaign, that we have now reconstruction techniques for free, should your case require a reconstruction. But if you present early, you will not go through this journey. Thank you. Thank you very much.
A round of applause, please.